Welcome to Near and Far, the World Catholicism podcast. I'm your host, Bill Cavanaugh, Director of the Center for World Catholicism and Intercultural Theology at DePaul University in Chicago.
Welcome, everyone. This is Bill Cavanaugh. I'm the Director of the Center for World Catholicism and Intercultural Theology at DePaul University. And this is another episode of our podcast series, Near and Far. You can check on our website to find the other episodes. Today, I'm delighted to welcome Alexandre Martins, who is a theologian and bioethicist from Brazil, who teaches at Marquette University in Milwaukee, Wisconsin, where he got his PhD as well. And he has a postdoctorate degree in democracy and human rights from the Human Rights Center at the Law School of the University of Coimbra in Portugal. He specializes in healthcare ethics and social ethics and has many writings, especially his book, The Cry of the Poor, Liberation, Ethics, and Justice in Healthcare. And he's also a professor in not only in the Department of Theology, but also in the College of Nursing at Marquette. And he's very active in networks that work on healthcare and theology in Brazil, Bolivia, Haiti, Uganda, and elsewhere. So welcome, Alex.
Thank you, Bill. I'm happy to be here.
We were delighted to have you participate in our online conference this spring. And I wonder if you could just begin by giving us a little bit of your own background, your own story. How did you get interested in healthcare? How did you get interested in theology? And how did you decide to kind of mix the two?
It's a good question and brings me to the memories of my own life. Well, I have a very interesting journey in Brazil with we call it basic ecclesial communities. The experience of the church in Brazil that has connected a lot of faith and social praxis in small communities led by the people. And as I grew up in a very social, challenging reality in terms of injustice and oppression, I have been very connected to the social activism for justice, for better conditions in my country to improve those situations. At the age of 14, unfortunately, I had to leave my parents to try to find something better in life. And I left home and I went to São Paulo, the big city of Brazil, and by myself. I lived there with an uncle, and there I get engaged through the church, the community there. And that church, they have like a volunteer work in a hospital to visit the sick. That's how I start to get connected to the hospital, and I get connected to the Order of St. Camillus. That is a Catholic order that serves to the sick. So that's how I got connected to the order, get to the church, the social activism, to that volunteer shift to more like a healthcare social activism. When I get age to go to college, I have no option to go to college. You know, I was a poor kid, but in Brazil, thanks to public education, I could try my luck to get in a public school, public college. In Brazil, it's good. However, it's extremely competitive. But I got in a philosophy program. Thanks God. And then since the philosophy program, I focus my interest like a lot of in ethics. And because my interest in healthcare, I focus in bioethics. And then eventually I decided to join the Order of St. Camillus. And the St. Camillus asked me, why you don't take nursing classes to help you? And then how I get connected, the philosophy background, and then I went to nursing while I finished philosophy in the Order of St. Camillus, and then theology just came naturally after that.
Philosophy first, then theology, just like the old seminary education, right?
But with nursing between.
With nursing between, that's a wonderful combination. Yeah. So could you tell us a little bit then about the situation? You've just been back to Brazil for a few months. Could you tell us a little bit about the situation on the ground there with regard to healthcare and the political situation as well.
Yes, I was in Brazil most part of this summer, and the situation there is very bad because COVID, obviously, we know that. But it's not only COVID. So COVID arrived in Brazil and found a very vulnerable, social vulnerable environment with a lot of lack of political and other leadership. The situation has become very conflictive in terms of healthcare because COVID, on the top of a previous conflict that already exists in the last few years that became very strong, is the conflict about the lack of resources for the public health system. Brazil has a universal public health system that has been built in the last 35 years. It's free healthcare, single pay, available for everyone in the country that covers the entire country. It's not perfect, but is provide good care. And 80% of the Brazilians, that's the only option they have. In the last 4 years, particularly 2016 was a key year when you have the impeachment of the President Dilma Rousseff, what I think was a parliamentary coup. And then from there, you move from a government that has kind of a social welfare state to a government that embraced a neoliberal agenda. And one of the things they did right away was to frozen for 20 years all the resources for social programs, including health and education. So the budget for healthcare in 2021 is the same that is in 2016, with Brazil having like 5% in average inflation every year. So only this you can see how the budget decreased. That create not a collapse, but a very bad situation in the healthcare system that have a structure but don't have resources to make that structure function for the good of the people. On the top of that, the government, when the election of Bolsonaro, opened for the new liberal approach of healthcare. So it's interesting. The day one that Bolsonaro started as president, United Health, a big health company, opened a business in Brazil because they couldn't operate in Brazil. But if the president promised them, if they elect, they will open for the international market of healthcare to operate in Brazil. So the government shifts from public health to sponsor that, what in Brazil called complementary health, that only support about 50% of the Brazilians, 50, that's the top reach of Brazil because they're extremely expensive and the model is very similar to the United States. And these have a lot of commercial advertisement or saying clear propaganda on Brazil TV now to say the public system is bad. We need private system. And then create that conflict that trying to shape the Brazilian mentality as well. Then came COVID and found that situation extremely fragile. And with the president deny the gravity, the bad situation of the COVID, and find the system very fragile. The private system, they just help that 15% of the population, but they also get overwhelmed very quickly. They couldn't support their own population, the rich population too. And then the public system actually has doing a better job than the private, even to support those top 15% of the wealthy people. So, but with the president denial, refusing to buy vaccines, and refusing to do to enforce measures like mask wearing, social distancing, those kind of measures, the COVID spread very quickly, especially in the most remote areas of the country, like the Amazon area. was the place we had the first collapse. And that's the region I actually worked in Brazil. I was in the Amazon region that came that problem of healthcare, previous, COVID in the top, and then I kind of conclude something. We have the land fightings. Amazon region is an area that has so many public land that was made reservations for indigenous people because the understanding of the Brazilian people when we became democracy again after the dictatorship in the end of 80s was the indigenous protect the land better than everybody else. And even before I have all those environment scores, and their lands belong to them. And you create those in the Brazilian constitution. But then when came the current administration, they have a mentality that indigenous, they prevent the country from progress. And they don't have an environmental agenda. So they start to support paramilitary groups of farmers to invade the indigenous land and exploit there and start. Right now is a war. The region I was in a small state of Acre, in the region of big Amazon, Brazilian Amazon, where they're in a war against those malicious groups supported by farmers and corporations and by the Office of the Environmental Ministry of the Presidency. Wow. So that's the situation. And tragically enough, land conflict, environmental issues, COVID. When I was there, in the community I was serving, we have an outbreak of TB and dengue fever.
Oh my!
So right now, my people work with me. My sister leads the project there, so they are dealing with those 4 things at once.
Wow. So there's a connection between the seizure of land and the kind of dual-track healthcare system, in that there's an ideology of privatization going on in both of them, right? This is a very old story. You assume that the private sector can take care of things better than lands that are held in common or a kind of common healthcare system. You assume that the free market, where property is in private hands, is going to solve all of the ills, and so the enclosure movement is still going on now today in Brazil. The idea that the free market is going to save us, it just doesn't seem to ever bear out, but it's very lucrative for some people, and so I wonder if you have any comments about that. I mean, in some ways, when you're talking about healthcare, you're not just talking about healthcare. In other words, you're talking about the whole kind of economic system.
Yes, you said very well, Bill. There is a strong connection between healthcare and the economic situation, the views that dominate the way that economy should be led now, and how the indigenous deal with the land. So when the Constitution, when the people in the Constitutional Assembly in 1988 wrote a new constitution, they have a question: do the indigenous people want have land as individual property, or they want to have a piece of all the communities can do whatever they want? The indigenous was unanimous, say we don't have that sense of land belong to a person.
Yeah.
There is no, it's very interesting. I learned all the time with them that sense of community. The land doesn't belong, I don't have my land, your land, and then you respect that. No, the land is the land, belong the land. It's like the land belongs to the Mother Earth. And you as a community, we use that for our good and for the good of the land itself as well. So it's a very different perspective. So they decide, so have those reservations, mainly on Amazon, in a way, it's not a private property of one indigenous family, another indigenous person, divide in pieces as we do in our Western mentality. It's just a big, and they live and they use and they go. There is no borders, nothing.
Right. So what is the theological basis, like a Christian theological basis for that view of kind of common ownership rather than individual ownership?
Yeah. I would say, first of all, it's not even a common ownership. There is no ownership.
God is the owner.
Exactly.
Right?
Perfectly. That is the view. God, the supernatural, is the owner. The land is like a transcendent entity, I'll put it that way, that we have to respect and have to care for, because the land provides everything to us as well. That it's theological. In the theology, well, there's many indigenous community. I'll tell one I have more contact. Two, actually. There is a tribe, the Guaranis. That's one I worked. Guaranis, so many different variations of the Guaranis. I work with Guaranis most in what today is Bolivia, Brazil, and Paraguay. Although, those division is made by the colonizers, but
right.
The Guarani country, I would say, that don't respect that. They have conflicts. Say they have a view when the land is not doing well, the community are sick. When the community is sick, or one member of the community is sick, one person is sick, the community is sick, the land is sick. There is that relation of the community take care of the individuals take care of the community take care of the land take care of the community.
Right.
Is that spirituality, because it's not simply technically speaking, but it's a sense of respect. It's a deep meaning of love and respect. Another community in the Amazon now in Acre, the Kaxinawas, is the name of the tribe. They have that deal that the land have their cycles. We cannot do everything anytime we want. And then the sense they have a sense of not accumulate things. It's like that. I am hungry. I go to the land, provide food for me. I don't need to work so hard to have food stocked for another month on the cost of the exploitation or the suffering of the land.
Right.
No. I trust in Catholic saying, probably I would say, they trust in the divine providence.
Right.
In the relation with the land.
It's our daily bread. It's not the bread that we,
Yes.
kind of store up.
And that is a deeply sense that in the Catholic or the theology or Christian theology view is that sense of respect for the land. The Pope Francis said we have a lot to learn from those communities, because they don't see individuals disconnected from where they live and from the people they live. Decisions are always made is from the other to me, and the other is the community or the earth, and not from what I think should be the best. It's all the opposite way. Of course, there are limitations. I don't want to show here like a romantic visions of the indigenous. As humans, they are not perfect as everybody else.
Right.
However, they have some worldview that has something to teach us. And that worldview is shaped with a spirituality of respect, of tenderness, of community, of caring. And all this is part of our Christian spirituality as well. But sometimes I I think sometimes because you became too much influenced by that technocratic Western development that prevent a way to go to that deep root of Christianity, that is care. When you see in Jesus in the Bible, when a sick approach to him, he doesn't go to say, oh, do a miracle. Let him at Jesus go, I am a doctor, go to surgery. No, he interacts with the person. I love that passage that when he's among the crowd, a woman bleeding, touch him, and she wants his help. He can just, because he was busy in his way to see the daughter of Jairus, he can just, okay, you need, oh, okay, heal you, go in peace. No, he stopped it and want to learn with that person. Show care, show tenderness. And then he used the gift he has to heal her. I could say, putting out, we don't do miracles like Jesus, but think about the healthcare provider. I have the gift of the technology that provide me the medicine, all those kind of things, but that should be used based on that sense of care, should be the base. And we have all the technology to make the land produce food for us, those kind of things. That's amazing. But that should be used grounded in that sense of care, of tenderness for the land. And that sense of care and tenderness, the indigenous has, and our tradition has as well, the Christian tradition.
So that's what you mean when you talk about the caring dimension.
Yes.
You use that phrase in your work.
Yes.
Yeah.
The caring dimension, I would say, it's a very common expression, the ethics of care, especially like people who, nurses, they emphasize a lot of that perspective of caring, but like a care spent in a perspective of like a view. See the world, the other, and the other here is everyone and everything, the nature, as some reality that I have to care. But it's not like one way, I care for the other. It's a both way. I care for the other, and the other care for myself. Leonardo Boff, a liberation theologian from Brazil, he has a beautiful book about, I don't, saber cuidar in Portuguese, I don't know how, that is in English, but I forgot how is the translation in English, but like knowing how to care. And he presents the perspective of caring as something part of our essence, in the sense we want to be cared as well we want to care for. So our nature is not only I want to be cared, but I want to care. But the technocratic paradigm, because everything became fragmented in that idea of infinite progress, sometimes suppress that view that we want to care also. And then you just emphasize we want to be cared, and that became individualist sometimes when I want too much for me, and I don't see that having for me means also share to the others.
Right. Yeah, as Paul says in 1 Corinthians 12, right, when one suffers, all suffer together, and when one rejoices, all rejoice together, right, in the body of Christ.
Beautiful say that. Sorry, beautiful say that, because my experience with the Guaranis, that was something I learned very quickly. I found a boy that one of my experience in the Guaranis who was having problem with alcohol. Unfortunately, it's a very common health issue in indigenous communities. Even here in the United States, they have those issues. So I have a young man, he was 19, 20 at that time, and he was struggling with alcohol. And then I said, well, I want to help him, but a conventional like rehab place will not work for him. They had tried before. Some other groups have tried before, like healthcare. I just start to see how I could try to help him when I understood from their leaders, the community, the indigenous leaders, that his problem was not his problem, was the community problem. The entire community was sick. And the way to help him we had to find an integrate way in the community. When the community will also start a process of healing together with the boy. And then all can be healed. Because he has the alcohol issue, but the community is also sick. And the way to address is not take him out of the community and put him like in a rehab clinic, as we do here, for example, in other realities, but trying to do something integrate in the community. That was the only way possible to approach without create more drama and damage for the community. Because before, people have tried to use a rehab for him, and that has created a huge conflict in the community.
That's interesting. So when you talk about structural violence and structural sin, sin is a matter of it's something that envelops the entire community. In one of my classes we talk, the students kind of debate. There are some kind of people that emphasize the personal nature of sin, that if you want to get somebody, if you want to stop alcoholism, it's a matter of kind of personal sin. You have to go to the individual and get them to stop drinking, and then you're going to have a better community, a better society. And then other people approach it, kind of the Marxist approach, that the reason people are drinking is because society is messed up and we need a kind of revolution, and then people will stop drinking. But what I hear you saying is that it's you don't have to choose between those two things. The personal is the political, the individual problem is the community problem, all at the same time.
Yes, I believe, and based on my experience, we don't have to pick one and other over the other. There is a relationship between both. The individual is part of a political society, and the political society are shaped by individuals. There is a connection in both in the relation that we can't simply dismiss to favor one approach to the other. And when you talk about structural violence, about alcoholism in indigenous communities, it's very interesting because you can track that historically, how that was purposely introduced alcohol in communities by colonizers and others to make them weak, to enslave them, to exploit them. At least in South America, the indigenous communities, they always have a strong tradition with smoking and some hallucinogenic substances. Like for example, something very popular in the indigenous community I work in Acre is something called ayahuasca. It's a kind of a tea that they have some visions, however, is that substances never has been used in an individual base. It's always in a ritual thing. It's like a liturgy. You never had, historically speaking, at least in South American tribes, I didn't find in my research any evidence that show individuals get addictive to a substance, to smoke. Or like, for example, in Bolivia, they have the habit to chew the coca leaf.
Right.
And that always has been a community. In Bolivia, it's very interesting because when the Spaniards arrived there, they discovered that the coca leaves could make them more resistant to pain, to work in the gold mines.
Oh.
That they introduced this to make them to use that outside of the rituals. That when you criticize, Bolivians use that now, and we remember to say why Bolivians are using that as individual base was a thinking created in the past to make them stronger to pain so they can work more until death in the gold mines of Bolivia to the Spaniards. That's the process. So you have to see that historical perspective, that's political, that is social, and then show how the structural violence has been present in history and is still present today. But that being said, you have the individual. When a person in a community are sick or having troubles, we have that historical and political context of oppression, but we have a person that suffers individually. And that person deserves attention and care because this person is important for the community. And the community will not be well until all the members are well. Mm-hmm. And be well there is the concept of the indigenous health. Bolivia has emphasized that I would call living well. That is very different perspective. Like healthcare is not you're sick and take care of your disease, but health is bien vivi, like living well. So and bien vivi doesn't mean I am sick and I don't have the disease anymore, but mean that integration in the community. And sometimes I still sick. For example, maybe I have cancer, and I still sick, and I am in my path to death shortly because of the cancer. But I still living well because the community is still with me and give me some dignity and some joy and meaningful experience until my death.
Wow, that's a very different approach than we usually find in our approach to healthcare, where death is the enemy and it's a war against cancer. You know, the kind of military metaphors that are so often used in healthcare.
Well, death is a very another niche. There is an indigenous of a tribe in Brazil, Krenak. The name of the tribe is Krenak, from the southeast of Brazil. And a leader, he's a international speaker. His name is Hamilton Krenak. I think it's worth one day you maybe talk to him. He's a great man. And he talks about, like, for example, he said about his tribes, we don't die. Only our body that disappears. All the noises in the jungle, of the trees, is still us. He said, I hear my ancestors. I hear my family. I hear my grandparents, my parents, through the nature.
Yeah.
And then in his community, he said that provides him even a bigger sense to care for the nature, because there is where they still alive in communicating through the sounds of nature with those who still have a living body.
How wonderful. Right. So I wonder if you can say a little bit about the combination of liberation theology and healthcare. It sounds like the approach that you're advocating to healthcare is really very much kind of from the bottom up, like listening to people, especially poor people without a lot of resources, about what health actually is. And I wonder if that's something that you picked up from liberation theology, or what the kind of cross fertilization is there.
Liberation theology, first of all, is not a thing. Sometimes here in the United States, in theology circles, you talk liberation theology as like a one thing separate, as like a theological discipline. I see liberation theology, and at least Latin American liberation theology, most of you agree with me, with all different views, is a perspective that will shape your way of doing theology. And what's the difference in that shape to do theology? Because it's from a new lens, and the lens of those at the bottom of society. In Brazil, the liberation does say the lens from the people, from the povo. No, it's kind of weird because people in English is not exactly people is just plural of person sometimes.
Right.
In Spanish, Portuguese, in Roman language, like populi, or populus in Latin, and a singular, and populi plural, because it's like a sense of a collective entity that could be plural, so it's not could be peoples. It's not only a group of individuals, but have an identity together. And then the liberation theology was understand that the people who best represent o povo, pueblo, or the people of God, like the Vatican II image,
Right.
is those who are poor. That's in Latin American context. Is where the majority is, where the faith is experienced more intensely. And in that reality, we make theology. Gustavo Gutierrez say, liberation theology is a new way of doing theology, because then we do theology from that reality where the people are. And that will change. Join to the people in the United States, you'll be one thing because the context is different. Join to the people, the poor people in Brazil, you'll be another thing, although can have similarities, but because they experience different historical situation. So liberation theology provide that new lens in which the people or the poor or the oppressed, they have something to offer. They are not only recipients of something. That's how the colonizers came to Latin America, the Portuguese and the Spanish. They came with a sword in one hand and a cross in the other hand, and then tried to impose the faith and the work on those people. We now are like a top-down approach. This is not acceptable. Should not be accepted at that time, but today is not acceptable. Even more clear, we should integrate with them and not see them as passive recipients of something we have to give them, but see them as active contributors of a process. So liberation theology emphasized that a lot. So then preferential option for the poor became it's hard, because our preferential option for the poor is an option to join the poor, to listen to them, to learn from them. At the same time, we offer something we have, but we offer something in a process that I call mutual learning, in which you learn from each other. The benefits of the development of Western medicine, it's amazing. We want that, right?
Right.
However, we want that in an interaction with communities in their own worldview, their own perspective, in which that the development of medicine can learn from what people have to offer in their reality from below, and that community can learn from that development and benefit from each other. So that's liberation theology, and that's healthcare. So in my perspective, never go to a place to impose anything. Even it's so, okay, I go to the indigenous people, vaccinations are objectively good. Yes, I don't question that. But there is a way I can work on that around with communities there to take advantage of the knowledge. And then they will learn the vaccinations are important, as we learn how you can make that more efficient and integrate in that community. So, and I conclude that the answer to this question will be with a very simple example, very quickly. I was in Haiti once, and then we have a complaint from the doctors that the Haitians who has heart issues and need to have heart medication to control, especially the blood pressure. Haiti has a huge problem with heart failure. It's a huge. So they come to the hospital, they get the medication control, they go back to the community, and then they have to come back like 2 or 3 weeks after to get more medication and do the follow-ups. So the doctor was complaining they are not coming back. And then they blame the Haitian people for that. And then one Haitian nurse said to the team. I was part of that team, and that discussion said, are we being fair to say it's their fault and take responsibility out of our shoulders? What is happening? Why they are not coming back to the follow-ups, and then they will eventually come when they are very sick and they need inpatient care. Well, that was a big problem. It's overwhelmed the hospital. And then she said, and I said, well, I think you have a fair question. How about you go to where they live and see what's going on? And then we decided to do that, even against most physicians didn't want, I don't live to the hospital. No, let's go to the community and see what's going on. And then we start to learn they are not coming back, not because they don't want, or because they don't care, or because they are like lack of gratitude for the healthcare they're receiving, but because the situation, most of them sometimes, they have to travel hours by foot or by animal, like a donkey or something, or in a little car that have like dozens of people in a car that's supposed to have 3 or 4, and they have to pay for that. They pay like, I don't know in American money, but I'd say they have to pay $1 to come, but that $1 can provide food for 2 days for the children or for themselves.
Right.
They will choose the food, especially for those who are parents. They will not take the money away from the milk they buy to feed their children to come to the hospital to get the pill. So, but we can learn that only if you take the step to go and join them. And that's what liberation theology teaches us. Then when you join them, we learn to be efficient with our resources and to be more integrative in the community, to get the trust of the community and to help them in the best way. We should not be just cross our arms in the hospital waiting them to come and complain when they don't, but go there and be part of the community and be companions of that healing process.
Right. Yeah, Paul Farmer talks a lot about that. I know you've worked a little bit with Paul Farmer, famous doctor, teaches at Harvard but runs clinics in Haiti, and has been he co-authored a book with Gustavo Gutierrez about kind of listening to the poor as the kind of introduction to healthcare, as the first thing you need to do to determine what people need to do. I wonder if you can say a little bit about your experience with Dr. Paul Farmer.
Well, yes. Paul Farmer is doing a great job in his organization. The example I gave is exactly happened in Paul Farmer's organization hospital in Partners in Health in the district of Mibale in the Plateau Central in Haiti. So was in his organization hospital, but he was not there at that discussion. But it's exactly his spirit is in what he trying to lead his team in his organization. Don't make conclusions right away to blame the poor for their own problems. For the join them, listen to them. He likes the word companionship. Well, the book you mentioned, he wrote with Gustavo Gutierrez, both mentioned, In the Company of the Poor. That's the title of the book. Because that should be the perspective. We are not there to simply provide something to the poor. We are there to be a companion in which we exchange. We provide what we have. If I am the doctor, if I'm the nursing, I have those skills that can help them. But at the same time, I'm open to learn from them, to learn what is actually creating the problems they are facing and how we, as a community, the poor and us among them, can take action to do something. It's a partnership with the poor. And Paul Farmer particularly is inspired about the liberation theology, and the motto of his organization is the preferential option for the poor in healthcare. That's the mission of Partners in Health. And he and everybody in his organization, those I worked with, became like part of the culture of the organization, preferential option for the poor. And
Right.
preferential option for the poor means, first of all, not being away from the poor. Even because what happened, Bill, I had an experience in Haiti, and I saw that also in my work in Africa and in Uganda. Sometimes physicians or health professionals or missionaries go with the best intentions to help the community, but they still away. They create a separate community where they eat separately. They don't eat the food people eat. They have special treats. They don't become part. They don't integrate. And that's not companionship. So that creates sometimes more conflict in the community because the community then don't trust. That favor racism and that perspective. That's colonialism. There's some group of philosophers like Boaventura de Souza Santos from the University of Coimbra. He has a criticism like to be careful because NGOs many NGOs became a soft version of colonialism because you don't work to empower and make them independent, but you want them to be dependent on us because you need them to make me feel good or looks good back home.
Right. Right.
Then if that happened in Haiti after the earthquake, many aid came and then creates some kind of a parallel economy. Like they have in Port-au-Prince, there is a part in the higher part. They create I would say a first world city inside with grocery store, everything, only for United Nations people, organizations people. Why they're living that parallel life, and they live there to go to see people in that suffer in Port-au-Prince. They're not part of the community. That's as Boaventura said, is a colonialism. We want the poor.
Right.
Because we are far away. I'm very critical of some philanthropy work. I think philanthropy is important. Paul Farmer's work is basically supported by philanthropy. However, you have to be very careful because sometimes our philanthropy is not to help, but to keep them poor. So you can enjoy our status quo and also enjoy, that's the evil, and I think that's a sin, a social sin. Also enjoy that benefit of being a great man, a great woman. Right. So the people that love me because I provide them food, and they don't understand the way I'm doing, I'm keeping them poor and dependent on me. But I'm exploiting them without them know. When you join, that liberation theology help us. The first process is conscientization, that big word, like make aware, awareness. That comes from Paulo Freire, and Paul Farmer mentioned that in his books too. Make the poor, help them to understand that process. Then I go back when I was young. My teen years in the Blaze Ecclesial community was the process to understand how the oppression occurred in the minds of us, of the people. And people in that context, why my dad, my mom, and my family couldn't read and write was intentional. Because if they don't know, they don't promote the difference. They don't change. They accept, they think is the historical determinism. Well, it's my fate. I was born to be poor. I will be poor forever. You'll be like those Aristotelian vision. A slave was born to be slave, it cannot change. And that we have to be careful not be promoting that when you do our work. That conscientization or awareness of the communities, it's very important. And we will not be able to promote that with them if you don't join them. It just being that kind of charity work apart.
Right. Well, let me ask you a little bit more about that then, because it's interesting. On the one hand, you see the benefits of a healthcare system that is not privatized, but has state support. But the state is a kind of top-down sort of mechanism, and you are talking about a kind of bottom-up approach. How do you think about the role of the state in healthcare? Do you think that healthcare ought to be kind of coming from the grassroots with state support? How do you envision how do you deal with that kind of tension between the top down and the bottom up?
Good question. I would say to you that the state, yes, is a top-down approach, but the state doesn't have to be that always. Depends how you organize the system. And I will tell based on my experience of how the Brazilian system is structured. So yes, it's top-down approach, the system, and I'm referring here to the Brazilian system in the sense is funded by the state, but that funding comes from all the community in a very system of contributive and distributive justice that go back to the Catholic social teaching. So we contribute the way we can, but everybody receives in the same way. However, if the state, they have a top-down approach in the sense they structure nationally. However, the way you lead the system and the way you deliver healthcare still can be a bottom-up approach. And I will explain based on how the Brazilian system is structured. The Brazilian system is structured based in called health councils. Each neighborhood, depending how many people live in an area, each neighborhood, sometimes a small town, or sometimes each neighborhood, have their community centers in which people from the community are part and they participate in the decision-making process. So although it's a state universal health care, one of the principles is decentralization. So they are run by people at the community level with those councils. And then you have that local level, city level, municipalities. Then you have state, so big decisions that, for example, like with COVID, now you need some kind of more coordinate measures. And then you have federal decisions. Special federal decisions will be more about budget, how much the government will be decide. But that budget is decided based on what the communities at the bottom level has been built and asked. I give an example. In my community where my parents live, you have that council, and that council is shaped by, you call, three segments, three kind of people: healthcare workers, healthcare administrators, and the community. So you have, and those councils, the government provide for them education, how understand healthcare, what they need to know. There's great programs. I was in the public healthcare system working, the Ministry of Health, in 2010 to 2012. We created at that time an online platform that people can be educated to work in those communities local level. So there, they decide together, they get together to make decision making, and they can prioritize what is their focus. For example, in my parents' community, previous COVID, one of the decisions, because they have a lot of dengue fever there, was prioritize actions to prevent dengue fever. The community decide that. The government will send the resources based on what the community asked for. Some communities have a high level of elderly population, so they need geriatric care. They need a doctor for that. They will request that the doctor, we have a geriatric care. Other community, maybe it's a very young community, and they need more pediatric care, for example. Or is a community struggling a lot with youth issues like STDs, alcoholic drugs. They will make the decision, they request, they have resources to address them. All that is building from the bottom of the community, and the manager of the system, or the local, they have to follow the decisions of that community council that everyone can participate, everyone wants. And then come the most interesting. The community became what you call in Brazil, is not a good translation, but you understand what I mean, social control. The community are responsible to control the health administrator if they are doing what they decided. And that is legal, and was institutionalized by the government, by the Constitution in 80s, that if there is instances, if they are not doing, they can report that and it's considered public failure to the state or local prosecutor. They establish an investigation to see if they are doing what the community decided.
Yeah.
So that's how was built to work the Brazilian system. So all community-based, and I went with an example of mental health. Mental health is a big problem. We all know that, and sometimes it's neglect, the treatment of mental health, even in the United States and many places in the world. And Brazil, mental health has been one experience of this community approach that has helped a lot. Before that approach, Brazil built those big hospitals and centers to isolate people with mental health. With that approach, the person who, every level of mental health necessity, integration in the community, with the community care for the person, with, of course, the professionals. But the person is still in their family, and the health center is not, okay, you take care of your child has a mental health issue, and they'll by your own, give medication. No, the community go to assist you. The doctors know where you live. The nurses visit you. There is the called healthcare workers that create that bridge. And then the person who have a mental health disease with any spectrum, for very moderate or very high issue, they are part of that community in the way they can be integrated in the education again, they can integrate in the working life and social well-being without being isolated in a center or in a hospital or those kind of things. I think this is a bottom-up approach, of course, with that top-down perspective, because the state is still being the funding source. And the state is still being also the one who create policies. And that's the problem we have today. This system has been dismantled now by the top creating policies to prevent the community to do what they had doing for years. We started that in 1991 and has been improved from 1991 until 2016. We have walked up. 2016, as I mentioned at the beginning, we frozen all the fundings, and then the legislators, the House of Representatives, became much more conservative. They have passed laws, and that's the research I'm doing currently. They have passed laws to prevent the development of the public system and to favor the development of a private sector in health. So because they can't end the public system, because it's a constitutional thing, to end that they have to change the constitution, they can dismantle it and to make them to be a very small system that doesn't work. And that is exactly what happened right now. Since 2016, many policies has been approved by the House of Representatives, dismantling the system, prevent the system from its normal operation, and doing that, they're doing other policies favoring the private system. One example is what I said, make a healthcare system insurance-based, with like the same system in Brazil. If you want insurance-based work in Brazil, was not like United States. There is no copay. It would be like a very simple insurance policy. You have insurance, when you need, you have it, and you have all things. Now we have a law that was passed in 2018 that allowed international insurance company to operate in Brazil, to have co-payment, high deduct, everything you know very well from
Sure.
the United States.
Yeah. Yeah, too well. Well, this has been a really rich conversation, Alex. I really appreciate this. I don't want to end on a down note. Pope Francis has called us to both be critical of the kind of structural violence that's out there and also be people of joy and hope. Let's end. Let me just ask you if you can give us a sign of hope that you see for the near future.
Well, I see a sign of hope, and I think the first sign of hope I see come from our leadership in the church is the Pope Francis message to the communities all over the world, in Brazil and other Latin American places. His message has touched deeply the heart of indigenous and the poor people. I think I see that as a sign of hope, because for many years, those who work from the communities inspired by liberation theology has been criticized a lot by the authorities of the church. It's the first time that the main leadership of the church, Pope Francis, have support those communities. And most of support with words, he has met some of those people. He now is preparing for a new meeting of the social movements. He had 2 meetings already, and he's prepared a 3rd one, where those people, indigenous, will go and see the Pope. It's amazing. It's for their faith, for the inspiration. And another sign of hope is the resistance. Although sometimes we get so sad what we see, especially in social media. Social media doesn't help much. They give a very bad picture. When you go to those communities now with COVID, for example, we see people helping each other with very small resources. And I see that everywhere, even here in the United States. People being creative to find ways. And that it's beautiful. It's a big sign of hope. And I think it's very evangelical, being creative in your reality. You maybe don't have the best health technology for you, but you still have your heart, hands, your time to find creative ways to support each other. And this, it's inspiring. I had seen like in the indigenous people in Brazil now with their fight against the malicious groups. Such a big, beautiful expression of solidarity among them in the way, even in that deep suffering, they find ways to care for each other. And it's beautiful.
Wonderful. Yeah, crises bring out the worst in people, but it can also bring out the best in people. And I'm really grateful for the way that you've held up these examples of joy and hope in a difficult situation. This has been a wonderful conversation, Alex. Thank you so much. Dr. Alexandre Martins, Professor of Theology and Nursing at Marquette University. Thanks, Alex.
Thank you, Bill.
Near and Far is produced by the Center for World Catholicism and Intercultural Theology, a research institute focused on Catholicism around the world, with special attention to the Church in the Global South. The center is sponsored by DePaul University, a Catholic university in the Vincentian tradition in Chicago. Production assistance for Near and Far comes from Marlon Aguilar, Finnegan Chu, and Karen Kraft. For more information on the Center and its activities, look for the Center for World Catholicism and Intercultural Theology on the web, Facebook, Twitter, Vimeo, and YouTube.